I think we've let everybody in from the waiting room. Let's just give a few minutes for people to connect. Okay. Good morning, good afternoon, good evening, everybody. Thank you so much for joining us today. Today's our first live session of just two for our Arthroplasty in Africa conference. This is the second year that we're running this conference. We're really happy to do this again. I hope that some of you have joined us for our previous sessions as well. But these are case-based discussions, and we really are happy to have you guys chime in among the participants with your questions, either in the chat, Q&A, or just unmuting and asking questions. We really are looking to have a lively discussion, so we look forward to all of your comments. Mohammed, next slide. Yeah, great. So this is the course agenda. So today we'll be focusing on hip pathology in young adults, mainly focusing on the indications and process of performing total hip arthroplasty in young adult patients. And then next week, we'll be moving on to total hip arthroplasty prosthetic joint infection management. So just, we're all very familiar with Zoom, but just want to let everybody here know that we've enabled translated captions. There's an ability to turn on your captions, and you can actually put it on for the language that you like. So set your speaking language to, if you were to speak in whatever language you would prefer, and then you can set your caption language to be whatever language you would like your translated subtitles to be in. And feel free, of course, to raise your hand so you can make comments and participate in the discussion. Next slide. So as always, the course objectives are very similar for all of our virtual conferences. We're going to work on improving participants' knowledge of arthroplasty principles, fostering international discussion regarding arthroplasty and management of complications, and motivate and support the younger generation of orthopedic surgeons practicing with limited resources. Next slide. My name is Kieran. I'm the course chair, and I'll hand it over to my colleague, Dr. Mohammed Kak, and his partner, Dr. Jeff Cross, who will be moderating today's session. Thank you all and welcome.
Hello, everyone. This is me, Mohammed. I'm an orthopedic surgeon from Iran, now doing research here at BIDMC Howard Medical School. Me and Jeff, who is an arthroplasty fellow at Brigham Women Hospital, will be moderating this session and the next one. This is our great team who did a great job to organize this meeting and conferences. We really appreciate their help. Our case presenters would be Dr. Valenzuela from Mexico, Dr. Yegon from Kenya, Dr. Esiyas from Ethiopia, and Dr. Anderson from University of Utah. We appreciate our international faculties, Dr. Hailo from Ethiopia, Dr. Latomia from Kenya, who joined us, and also Dr. Lopondo from Tanzania and Dr. Bargoria from Kenya. Our US faculties would be Dr. Weaver and Dr. Baratz, plus Dr. Wickstead and Dr. Anderson. We appreciate your time. Our course agenda would be, we would start with Dr. Valenzuela. We have 3 presentations, maybe going to 4. Each presentation would be for 15 minutes, and then we will have 20 minutes for discussions. Dr. Valenzuela, if you're ready, we can start with your cases.
Yes, I'm ready now.
Will you share your slides, or Kiran, you will do it? Thank you.
Can you see them there?
Yes.
Yeah, Kieran.
Okay, great. Go ahead.
Yes, I can see them. Yeah. Okay, can I start whenever?
Okay. Yeah, you can go ahead.
So thank you very much for having me. I'm Dr. Jorge Valenzuela. Even though the title of the talk is Arthroplasty in Africa, I thought that the case that I will be presenting today will be very informative or instructional. So I decided to send it, and I'm very grateful to be able to present it today in this session. So as you can see in the slides, I was born, trained, and raised in Mexico. I was trained in my residency in the Hospital Magdalena de las Salinas, which is in Mexico City, one of the largest trauma centers in all of Latin America. And I'm currently practicing medicine in Sonora, the hottest region in all of Mexico, currently at 50 degrees every single day. So next slide, please. For this case, I will be presenting a 33 years old male. Only references, he says that occasionally he smokes, he has no other known conditions, and he's currently pensioned. Why? Because, next slide. When he was 15, he had a motorbike accident which caused a femur diaphysis fracture, as well as an ipsilateral tibia diaphysis fracture, as well as a non-specified midfoot fracture, which was treated with an antegrade femoral nail, a tibial nail, and a midfoot amputation. So after this accident, there's no records, there's no paperwork, there's nothing that can be helpful to identify what kind of treatment was made at the moment, how many surgeries he has. But he mentions that it was done all in a single time. He was at the hospital for a long time, not at the same hospital that I'm currently working at. But he says that after he was let go, discharged from the hospital, he had no known problems. However, 17 years later, when he was sleeping, he says that he tries to turn in his bed and he hears and feels a crack on his left leg, specifically on the region of the hip, starting with pain, and afterwards he was unable to stand and properly walk. So he decided to go to the ER of the current hospital where I'm at. Next slide, please. These photos are only to show that he had the tibial nail, which was removed, next slide, on 2022. And next slide, please. These were the x-rays that were presented when he was admitted into the hospital with the femoral nail with a lot of new bone on the side of the fracture, as well as a fracture on the femoral neck on the left side. So he was admitted into a hospital. The surgery was planned to have the nail removed and then put a primary hip replacement. Next slide, please. But since we started planning, as soon as I got the case assigned to me, and as soon as we were starting to do all the workup to have him going to the OR, it was undoubtedly a weird case, and there was a lot of brainstorming about what we can do. Seeing these images, seeing what had happened, does anyone have any ideas of what it could be or what the diagnosis could be?
Any of our US faculty want to chime in?
You go back to the x-rays.
Yeah.
Yeah, certainly that looks concerning for a subacute process. That doesn't look like an acute fracture. You know, there's sclerosis, particularly on the femoral side, and things are a little bit rounded. I don't see signs of an erosive lesion like a tumor or something, but certainly this is concerning for some kind of stress fracture that completed or something that happened a while ago and he's been like this for a while and then something changed, but it doesn't look like an acute fracture.
Do you?
So we were thinking, yeah.
Sorry, I was going to say perhaps the piriformis entry nail had something to do with this as well, right? Because those can be associated with femoral neck fractures.
Yeah, I would be.
So we all had.
I already know a little bit about the case, obviously, and I agree with Dr. Weaver. I think that a subacute process does not look like acute. I think depending on the time span between the initial injury and this presentation, if this were like 6 weeks or 6 months even, I would think that it might be a missed femoral neck fracture that completed. But this was what, 2 years between presentation? Is that right, Dr. Valenzuela?
No, the nail was put when he was 15 years, and 17 years passed since the femoral nail was put on. So he had the nail put in when he was 15,
Yeah.
And he's now 33 years old.
So 18 years have passed. So it's not a missed femoral neck fracture. It's most likely like a avascular necrosis type thing. Although the head does not really show any signs of AVN on this X-ray. Perhaps an MRI would show that if we were to obtain it.
So continuing on the case, all of those ideas were mentioned during the workup of the patient. Certainly it was something weird. I initially thought that it might be a case of avascular necrosis. However, as you have mentioned, doctor, there were no, the images weren't coinciding or weren't as you would expect for a vascular necrosis. So due to several factors, I want to mention here ahead of the case that I myself do not consider this to be a case of success, but undoubtedly a interesting case, maybe a case for learning or for research. However, in my opinion, I do not believe it was a success case, as you will see on the following slides, due to many factors. So he was planned for a primary hip replacement. On the center that I'm currently working at, we are kind of limited on the resources that we have access to. There are occasionally revision components, but most of the time we only have access to primary components, and these are not always available. So we may be able to be putting a primary hip replacement for a fracture, and a long time may pass before we're able to use another one for another patient. There are some times where we are able to do it very quickly, and others that we can have weeks or months between available components. So when we started the surgery, I made a normal approach. I used a lateral approach for the hip. And as soon as we open up, trying to remove the femoral nail, I don't have pictures since I didn't think that I'll be showing this case anytime soon. I hope I could have taken some pictures during the surgery. But I found that the nail was not in the position that you would expect a femoral nail to be put in. It was too posterior. And as soon as I'm trying to do the removal, I noticed that there is the vascular necrosis of the femoral head, and there was no neck, as well as an important compromise of the greater trochanter. And when I was trying to remove the nail, maybe I blame my technique doing it. Where the lesser trochanter was also compromised, even though all the bone quality wasn't as good as you would expect for a 33-year-old. I believe secondary to the smoking. He's been smoking since he was like 13, as well as since the amputation, the midfoot amputation is on that same side. His walking is not as normal as you would expect, so there was kind of some lower bone quality related to that issue. So next slide, please. I took this picture during the surgery of the head, where you can see that there's a lot of loss of the bone, a very bad quality of the bone, and signs of the vascular necrosis. Next slide. So this is the immediate post-op picture. As I mentioned, I do not believe this was a case for success. The greater trochanter was greatly compromised during the removal of the nail, since I mentioned it was very posterior. The place that it was placed wasn't the most optimal one. So I made, with the available components, I tried to reconstruct the greater trochanter as much as possible, as well as to place the lesser trochanter as in the best position that I could. He was let go of the hospital after 2 days. Next slide, please. This is the first revision at the clinic that we have after 4 weeks. There's a little bit of new bone being made, especially at the lesser trochanter. The patient was mobile. I mean, he wasn't walking, but he was able to move. He had no pain, and he said that he felt great, even though the images weren't as perfect as I would have hoped. Next slide, please. Then this is the second consult that we had at 8 weeks. And to my surprise, when I'm calling the patient into the consult room, even though he was advised not to do so, he was walking without no walking aids. He He was
Crutch.
walking with no walking aids, and during the questioning, during crutches, yeah, thank you. During the interrogation, he mentioned that he was seen on a Monday. That same Saturday of the past week, he was riding horses at his ranch, and he said that he felt great, that he felt that he no longer needed to wait to start walking, and that he believed that he was going great since he was able to get back on his horses. He referred no pain. He was walking with no issues, even though he was advised not to do so. I called him out and I told him that he shouldn't be doing that yet, that we should be waiting a little bit more since the progress from the 4 weeks to the 8 weeks was a little better than expected. But I still believe that it's way too early to start walking without any assistance due to the loss of bone on the lesser trochanter. Next slide, please. So from the start, it was a weird case for everyone. So I did a little literature review that I wanted to share that I consider that will be useful for this session. Next slide. So there have been very few cases reported of the vascular necrosis of the femoral head after a femoral nailing. It's especially reported skeletally in mature patients. I found one case report that only listed 14 cases since 1998, and it mentions that it's especially more prevalent if an anterior grade nail is used that is designed for adults is used in children, especially due to the large size, the large entry point that it requires, and a larger width of the nail. Next slide. Most of the cases were reported in children, previous one, please. On children that were 10 to 13 years. Some cases were reported in patients that were older than 15 years old. And very low incidence in a posterior review that was a report, that was based on the first one that I mentions that there's only a 0.2% incidence of this avascular necrosis of the femoral nailing, especially if the nail is placed in the trochanteric fossa. And usually in the adults, the entry point does not matter. However, next slide, it is said that in children, more posterior approaches, like the one that I mentioned that I found in this patient, has the risk to injury or compromise the vascular supply of the ascending superior posterior branch of the medial circumflex, which afterwards can cause a vascular necrosis. The distance in adults is around 15 millimeters, but in every patient that is less than 50 years old, this size has been found to be between 9 and 10 millimeters. Even though it's a very small size or small size difference, it has found that this insertion or this point, even especially if it's more posterior, will increase the risk for of injury to the superior branch of the medial circumflex, especially, as I mentioned, if implants that are designed for adults are used. Next slide. So some reviews report that especially implants that are specially designed for children should be used. We have none available currently in our country, so most of the cases are managed either with TENS or with elastic titanium nails or with adult design nails, which was used in this case for this patient. There's also some cases or some recommendations that mention that you should use a dorsolateral entry point below the trochanteric physis for children when trying to use an antegrade femoral nail. And in combination with what I would learn or try to do differently with this case was that, as I mentioned, since they are not readily available in all cases, we didn't have revision components. I have some people on the AO forum where I posted the case mentioned that as soon as I saw the necrosis and the quality of the bone and everything, I should have closed the incision, waited to request revision components, and work on putting a femoral support revision femoral component instead of using primary components. However, as I have said, if I had done so, a couple more months would have passed until the patient was able to have the revision components put in. We work in a work environment that is saturated with patients. There's not enough opportunities or OR time for patients to be able to be accessed and operated on. So I thought that I would give it a try. I will give him an opportunity to work with primary components and see how much we could gain, how much functionality we can gain until I believe the inevitable failure of the components and the requirement for a revision component, which can be requested, planned, and have available for an OR instead of seeing maybe when we will be able to have them ready for the patient, especially since he, despite my comments on not doing so, he's been riding his horses, walking, and moving around as much as he wants, mentioning that he could no longer stand being in bed after a couple of months, especially since he had to wait a long time for the first surgery to be done. Next slide, please. So I believe there's a lot to learn about this case. As I mentioned in the start, I do not think this is a case of success. That may be available. I think that there were a lot of things that could be done differently, a lot of opportunities for different management or different treatment options to be used. The progress of the patient so far is satisfactory. It's better than I expected, really. Seeing him walk was a great surprise, maybe not a very pleasant one, but a great surprise indeed. And he's going to have another consult meeting shortly for his 12-week follow-up, which if anyone's interested, I will be sharing that to see how much progress he's done, even after riding his horses. And surely, as we all been questioned and in all the surveys that we do for these kind of sessions, we should all have maybe all the components ready. Sadly, they're not always available. And taking all that into consideration, I think that what we managed to do was acceptable. Maybe something better could have been done. Maybe if I was a little bit more careful. But overall, I think that we managed to do what the best we could do in the current situation. Next slide, please. So thank you very much for your time. This is an Indio Jackie that is from the region that I currently are born from, or local tribe. It's very hot. There's a lot of good food. If anyone wants to visit the north of Mexico, bring shorts and be ready for a couple of good beaches and a lot of seafood. Thank you very much for listening.
Thank you, Jorge. Case, and I think extremely relevant for the topic here. Young person, obviously, but also the challenges of having limited access to the implants. I'm going to just back up to this slide here at 4 weeks, just for the purpose of this. Go ahead and take it away.
Okay, thank you, Dr. Valenzuela. Yeah, it's evident that you put a lot of thought and effort into managing this case. Great job. Any of the faculties, Dr. Weaver, could you share your thoughts on the challenges and solutions presented in this case, please?
Sure. Certainly, if you want to go back even further to the film that shows the nail in place, these can be very challenging. Removing femoral nails, particularly years from their insertion, can be really difficult. The hardest situation I've had this way was a friend of mine sent me a case. One of the children's doctors who's actually still in practice, Lyle McKaylee, put in a slotted Künstner nail 45 years ago when he was early in practice. And the patient came back and needed a hip replacement. And so we had to take it out. And I think I broke 13 or 14 instruments removing it. Fortunately, this is got a threaded top, which makes things a lot easier, but you don't have the record, so you don't know which one it is. And so I think, thinking through this stepwise, getting these nails out without hurting the bone can be challenging, particularly with osteopenia like you have here. In my mind, that you're going to be putting wires on this, particularly if you're going to do a press fet, you're going to want some kind of prophylactic fixation. So I'd recommend doing that before you remove the implants to kind of stabilize things and give it a little bit more support. And then the second thing is I always use a I always use a nail insertion kit to get these out, even if it's a different one, because you can use the threaded guide wire to gain access to the top of the nail, and then you can ream over it to ensure that there's no overhanging bone. Because if you try to remove this with any overhanging bone, then you can have a fracture. So I think prophylactic fixation before you remove it, and then really clearing the top with an oversized drill is helpful. And then when it comes to stem selection, certainly it sounds like you're limited in your choices. I personally like having a diaphyseal engaging stem, even if it's a primary stem. So currently I use Wagner type stems. But when I started, I used an old Zimmer 6-inch full coat, which was a really solid stem. It's bulletproof, and it is a primary stem. It's a little less expensive than a lot of the revision things, and you can get good fixation. And then the last thing that just jumps to mind is anytime I'm press fitting in a fracture situation, I like to protect the bone below the fracture or the fixation. So even if I hadn't put prophylactic wires on before I inserted this stem, I would put wires on the intact bone. I think, this is going to be fine, but I think prophylactic fixation before press fitting and compromised bone, I've never regretted it.
Yeah, I would echo the
You
same.
know, I was kind of worried when using the diaphyseal support stems, since here in the post-op picture, the femur diaphysis looks, well, weird due to the forming. So I was worried that maybe the femoral the diaphysis stem, maybe when being impacted, may break. Maybe it will cause an trans-up fracture of the diaphysis when impacting it. Maybe if I chose a vast stem that was too long. So that was also a worry that I had, that maybe if I had the diaphyseal stem, maybe I wouldn't be able to place it, or maybe it could be a break, since the quality of the bone wasn't as good. And due to the deformity that it has in both planes, I was worried that it may not be as good, since the diaphyseal stems that we have are way too long. We don't have short stems.
Yeah, the advantage
That was
though, is
also
you did
another
have
limitation. I thought maybe.
Yeah, the advantage is if you are removing a nail, there was something straight and long in there, and so often you can't chase that. Although certainly I agree, if you put a really long stem in here, he's a young guy. You're going to be someone 20 years from now will be in a dark place.
Yeah, I'd echo the same thoughts of Dr. Weaver, just either using an over-reamer on the top with a nail removal kit. But if you don't have that, you can use a osteotome or a burr, remove a lot of the bone. Your neck cut's going to be a little bit lower, so you can remove that bone. And there's often ingrowth of bone in through the holes, and it's much stronger than you think. And you knew going in that he was going to be osteoporotic with that kind of ghosty looking greater trochanter. And I've had the same thing happen where you think you have access to the top of the nail, you start trying to bang it out, and part of the troche goes with it. So I think being aggressive, removing bone around the top of the nail will save that from happening. And also would echo the thought, putting after you do have the fracture, putting wires down below the level of the bottom screw, I think would be helpful, especially with a guy that's not going to be compliant. Yeah, right down there. I think this is a great case for that incoming world hip, where you have kind of a Cone Wagner type stem that's going to hopefully be available around the world.
Uh, Sammy and Violet, yeah, go ahead.
Yeah, thanks very much. I think this is a very interesting case, and I agree with most of the things that have been said with the other guys. I still have a lot of problem knowing whether this was really an avascular necrosis, and probably because of the insertion of the nail, and it was more posterior, probably yes. But then there's underlying osteoporosis, which could easily cause a traumatic fracture, as it happened to this young guy. And I think this could be avoided by using a flexible nail. I think they use a sign nail, that's what he said. So I think that could be avoided. And this is something that we should actually take home as a message. We try to avoid the worst scenario in this kid, because, I mean, he's young and we don't want him to get a total hip replacement. So we should initially, they should have used a flexible nail, which is less traumatic. But it could still be a missed fracture. I don't know. I still have that in mind. It could be a missed fracture, and probably somehow, somewhere, the healing process, because of the compromised blood supply, because of that entry point, will lead to this traumatic fracture. And since it was there's an obvious osteoporosis, I don't know if there was a room for cemented hip because of the bone quality. But again, was there a room for non-arthroplasty procedure? Because the head looks like it's okay. We were told the neck was lost. And I know there's now an increasing trend to do valgus osteotomy. I don't know if we could actually leave this patient and do a valgus osteotomy if it is it's an option. I'm not very fond of doing that. There are people who are doing that now, especially in India. There's a lot of series of these cases. So I was wondering if there was that room of having a valgus osteotomy in this patient.
Dr. Lopondo, you mean like trying to fix the fracture, the femoral neck fracture?
Yes, exactly.
Would you have tried to do that, salvage this? I mean, is that something that you would have tried?
I don't do that, but there are people who are doing that. If the head is okay, they would probably do a valgus osteotomy. So I don't know if among the faculty they can comment on that. I was just wondering if this is an option in this case.
I think with the missing neck, you don't have an option for that. And I suspect that head is just floating around.
Oh.
Yeah, I would love to see a CAT scan, but I agree. I think that this is months old. It's and that there's a lot of bone loss, so I don't know that an osteotomy would fix it. Although I think your point of avoiding an arthroplasty in a young person is always worth a good try. So doing the fracture fixation the first time, the best you possibly can, pays dividends.
I think especially in settings where arthroplasty is not available, which is, I think for many of those in our audience, that may still be the situation for them. And especially the availability of complex arthroplasty components to fix, diaphyseal fitting components, things like that.
Yeah. I commend you for presenting this case too. It's very easy to present the case that's high fives and looks fantastic. But often those aren't the ones where you learn from, and certainly I've learned something from this one. So it's a great thing.
Certainly.
I would add to that defining success may not be how beautiful the x-ray looks. And I would say if this guy's riding his horses and he's not having pain, I mean, this was a challenging case over time. I would say you're being very humble by saying you're not successful. This is a success. That lesser fragment will eventually heal. If he gets fixation of that stem, he will be happy for many years. And yeah, I agree. It's a good learning case. I would say that there's, you can always, the next one maybe will be different. Maybe you do wires ahead of time. Maybe you remove more bone. There are people that would even do 2-stage this operation. I think I would have done it in 1 stage, but there are people that would take the nail out, assess, come back 2 months later, then do the arthroplasty. I like doing 1 operation for a patient when possible, but there is some value in doing it in 2 stages as well, particularly if you're worried about infection.
Thank you.
Can I ask about your weight bearing status and that sort of thing immediately post-op? Sounds like you had him non-weight bearing, right? Because you may have been worried that the stem wasn't completely stable, given that this seems to be a metastasis.
Yeah, I was waiting to starting on weight bearing. On that console at 8 weeks, I was planning on having him start weight bearing with the crutches, but I saw him coming walking, so he went a little bit ahead of schedule.
All right.
Yeah.
I think that it was a very conservative approach on my side, not wanting him to weight bear a bit too early. I was worried that maybe the little bit of bone that had been done or had consolidated here on the lesser trochanter may snap, or maybe the wires may break. I don't know. I was very worried about everything. But as soon as he said that he was riding his horses and he was feeling great, I said, we have a phrase in Spanish, that says Dios cuida su rebaño. God looks after his sheep. So I think he's been taken care of very greatly. He's been very lucky.
I think this
Sorry,
patient,
if I may comment.
yeah,
So-
I say in an environment that we are, like in the area where we don't have a lot of options to do, I think this will be the option that we take. At least we have an option of using a Wagner stem, but I think for the cap, we should have used also constrained cap so that to reduce the possibility of instability. But again, this patient is the patient who had a midfoot amputation, and you wonder how did this patient manage to walk as well I mean, after surgery. It's really a unique case, so to speak.
May I ask if
Yeah, go ahead, Mark.
the presenter considered infection? Has infection been considered and ruled out in this particular case? I also would like a little comment from my colleagues about use of cemented prostheses that the lady doctor suggested. What would be the comment? Because I would also have considered that looking at this situation, because impacting non-cemented in this hollow osteoporotic bone is undoubtedly likely to lead to a fracture. So what would be the comment on cement, and has infection been completely ruled out?
Great question.
Yes, when he was received on the hospital, we did an infection workup and everything was negative. As well, when I was removing the nail and preparing everything, I did a little timeout when I was waiting to see if I could do the primary hip replacement at the moment. As you mentioned, Dr. Weber, I was waiting on to see if I would do it on 2 times, on 2 stages, or on a single stage. And I took some cultures, some biopsies to send to the lab to see if that there was nothing, and those turned out negative. And on the cemented components, the whole issue always is the kind of contracts, the licitations that we have on the materials. We previously had a cemented hip replacement, but it has to be ordered per patient, and it requires around 1 month to be provided to a hospital. So during workup or the planning, it could have been useful, I agree, to request for the cemented component to be brought in. I also thought about doing an augmentation, maybe add a little bit of cement on the lesser trochanter, but I wasn't sure if that would be a good idea, so I didn't go ahead with that.
Seems like it would be a little bit hard to contain the cement with the fracture there at the calcar.
Yeah, exactly.
Sammy, any comment on whether you would use cement in this
Yeah.
case, or how you would have made it?
No, I don't think I would consider cement here. To begin with, he's a young patient, with this fracture around the proximal femur. I think it will affect the healing process. It might affect the healing process of the fractures as well. And, down the line, revision is not going to be easy either. So I would consider to use a prosthetic stem, but definitely, I would try to maybe have a Wagner type of stem and use 2 cables if it is available. One cable to fix the lesser trochanter and calcar area. One above, looping it around basically. So one above the lesser trochanter, and then I will, make a second loop below the lesser trochanter, below the fracture. And then use a cable to fix that, and then I would use a second cable to fix the greater trochanter in a figure of 8, or the other option is with the Wagner type of stem. If you have the smaller type, you know, which is available in our setting. We could pass the cable through the hole on the proximal part of the stem, and you know that can be used to fix the greater trochanter down to the native proximal femur. And you know that would help, and definitely you know when you use the Wagner stem, the technique is simple. Basically, you first stream and then trial. You don't have to do any broaching or anything. Basically, you know, after you put your stem, or even before you put your stem, you can you know wire this prophylactically below the fracture as well as above the fracture, and also fix the GT with 2 cables. And definitely, I wouldn't use you know a cemented stem for this. You know, so salvage, what was discussed earlier, is something I would definitely consider. You know, obviously, getting MRI might not be easy, especially if you don't have you know metal subtraction MRI in our settings. You know, looking at AVN might be difficult, and even in the even if there was no AVN with that amount of neck loss, it might be difficult to consider a salvage. But you know, it's something to consider in our settings where you know we don't have every sort of fixation replacement modality available. So with MRI, you know, that's something I would also consider to begin with. So I would like to hear the other faculty's opinion about their technique of fixation of this sort of fractures. I know you would also do it in part-rock fractures as well, right? Like in elderly, when you have part-rock fractures comminuted, you would consider primary hip replacement. So what's your thought on the fixation technique?
I personally think cementing into this case would have a lot of challenges, and you know, when you're trying to cement into a previously instrumented canal with that nail, I mean, you can still see on the post-op X-rays that sclerotic line. I don't think you're going to have much of a cancellous bed to cement into. So I would say cementing. I would almost never cement this. I suppose potentially on a very elderly osteopenic woman, but I would, if you are going to cement this, I think you're going to have to do some sort of impaction grafting type technique, which is really challenging. And with a younger patient, this gentleman, I think, is only 33 years old. I would not plan to cement this case.
I agree. I would do the same thing. And I would typically use a primary implant like this or a Cohn-Wagner. And when I have cemented, I've done impaction grafting. If you don't have ghost brooches, you can use the head and just use a polished stem as your ghost brooch, and use it as to broach the head bone into the canal. You can also take some of the neck pieces and slot them in as shingles to keep the cement from coming out, either through screw holes or defects in the calcar. But yeah, much more difficult than just using a primary stem, I think, in a patient this age.
Thank you, Dr. Valenzuela and faculties for commenting on this case. It was really challenging and good. We have Dr. Yegon on board if we want to keep on our agenda. Dr. Yegon, are you here?
Hi,
Hey.
I'm here.
Hey, thank you for joining us. Could you please share your slides? Dr. Yegon is going to present DDH type 4 for us. Go ahead.
Okay, so let me go to the start. So I'm Yegon. I currently work at Tenwek in Kenya. It's a mission hospital in rural Kenya. I finished my medical school some years ago and residency a year ago. So a case of this is a 24-year-old lady who presented with left limb shortening since early childhood, and came because she was now experiencing a lot of pain in the back and even walking. And so she wanted something done about this. So what she reports is when she was younger, she had some surgery done in the hip, but the exact nature of the surgery was not known. So when we saw her, the examination She was limping, short leg gait. She was tiptoeing, of course, to compensate for that. But on examination, of course, she looked like she had some equinus, but on the examination, it was quite supple and not fixed, no fixed deformity. Ductal strengths were normal. She had an approximately 5 centimeter limb length discrepancy, and a neurovascular exam was normal. So in the radiological exam, this is her X-ray. This is how she looked. You can see how much shortening she has. The dysplastic acetabulum with almost absent. In this X-ray, you think she didn't have a femur, head of femur. And you can see also the hip is completely dislocated. So this would be a CRO4. We went ahead and got a CT scan for her, and you can actually appreciate, let me see if I can get a pointer. You can actually appreciate this is the head actually. The head that deformed was also dysplastic, just sort of remodeled to accommodate to how she has been working for almost 10, 15 years now. Then this is just an axial cut showing the acetabulum. You can see the acetabulum of the contralateral side is quite normal, looks good. Then you can see on this affected side, the posterior wall is almost absent, just a small sliver of the posterior wall, but you can see how thickened her medial wall was. She still had some anterior wall present. So this is just the normal hip. Then this is what you are dealing with. So you can see the whole acetabula is completely dysplastic, just from a lot of years of remodeling from not being in the correct position. So so pre-op planning, of course, this thing, the first thing you always ask yourself, do you even want to do this case? Looking at the challenges you're facing, very shortened, the acetabulum is all, the posterior wall is missing, the anterior wall is small. So that was the first thing we kept wondering, going back and forth, do you even really want to attempt to do this? Then the kind of implants we were thinking about, we thought of a diaphysial engaging tapered stem. The one we had available for us is a read-up stem. And we thought of multi-hole cap if needed, so that in case we are reconstructing that, and of course, sacrilege wires. The reason we thought of the diaphysial stem was looking at how shortened she was, we likely would have needed to do an osteotomy just to reduce that hip. The approach we went for was the Kocher-Langenberg. And then, of course, what you are thinking about, like I've said before, is sciatic nerve palsy, which usually occurs whenever you try lengthening above 4 centimeters. The risk of nerve injury goes exponentially high. And also thinking of a subtracheostomy. And then for the acetabulum, we had, you could see there was some acetabulum, though it was dysplastic, had some posterior wall, though it was small. The thickened medial wall was quite nice because gave us some room to maneuver, because you could actually medialize the cap a little and still have some place to place your cap. So we thought of the smallest cap we could get, which for us was available was of size 46. And then there was this article which I particularly found helpful, which describes just a surgical technique of managing this CRO4 kind of dysplastic hips. So, okay. So this was the X-ray. So we had to do a subtracheostomy. She was quite short. We put 2 sacrileges initially. We put one just at the level of the osteotomy, both on the proximal and distal segment. But during the reaming of the stem, we got a fracture of the diaphysis. which this part we noticed on X-ray, but we had noticed fracture propagation on the distal segment, which prompted us to use extra sacrilege wires just to hold it. So this was the post-op X-ray. And then for her instructions, we went for toe-touch weight bearing for 4 weeks on account of the fracture that we saw post-op. Hip stretching exercises, she was quite tight. As you can imagine, she was quite shortened for a long time, so she was quite tight. We had to do some Achilles tendon stretching exercises. We put on aspirin and analgesics and prophylactic antibiotic for 2 weeks, given it was a very hard, almost a very hard primary hip case. So this was her immediate post-op AP X-ray. On this other side, on the left side, which we had, she was a little long, about 1 centimeter long. That is on X-ray. But even looking at her physically, she was actually almost same length, about also 1 centimeter. But in terms of her ambulating, she didn't even notice the difference. So she came at 6 weeks. So this post-op examination, so for a post-op examination, when she came, after the 6 weeks, the incisions were healed and the nerves are still intact. The main complaint when she came at this point was she was having a very bad case of plantar fasciitis and neuropathic pain, but her nerve was still firing as normal. At this point, she was fully weight bearing as tolerated. We didn't yet have a radiological union of this, but we thought the fracture was stable enough that she could weight bear on it. So just on discussion of this case, I think it was a case of a dysplastic hip and how to handle it. In terms of resources, of course, we are usually limited in the type of implants you can use. Getting the diaphysial engaging stems is not particularly easy. And also just the technical bits of this case is not easy at all. A lot of things can go wrong, including fractures, which we got, like here on the femur, on this AP, but on the lateral, it was not propagating. And then, of course, you have the risk for nerve injury, which is always a risk. Despite your best efforts, you always risk injuring that. Then post-op, we've also started noticing is a lot of these patients, you can imagine for a lot of years, they've been walking in equinus. So once you bring that foot down to almost neutral, what you get now is a very bad case of plantar fasciitis just from how the foot has been for quite a while. Yeah, so these are my acknowledgements. Yeah.
Thank you, Eric. Can you go back to the original X-rays before your surgery? Maybe we can start from there with a discussion.
Okay.
Okay, perfect. Thank you, Dr. Yegon. That was an excellent presentation. I appreciate how you navigate the complexities of this case. So this time I begin with Dr. Bartz, and all the faculties are more than welcome to join us. What are your insights on the treatment decisions made for this patient? And especially, could you share your thoughts on the importance of CT scan in preoperative planning of total hip arthroplasty for patients with severe DDH?
Yeah, thank you. First of all, I'll say this, in Boston, Massachusetts, this is a problem we don't see very often anymore. You know, it's just, we're so, I guess I would say maybe aggressive and careful, you know, about screening for this type of condition early on. So, you know, Boston has some incredible pediatric orthopedists and pediatricians that, you know, don't miss these types of things. So my experience with Crow-4 DDH keeps getting worse and you know, less. I haven't done a Crow-4 case in 10 years, probably. Since I don't even know if I've done one since I was a fellow. I would imagine south of Boylston Street or Brookline Ave at the Brigham, Mike Weaver would feel the same. I don't know about Utah, if Utah still sees some of this, but But I think that the approach that I would have taken to this would have been the same in terms of, CT scan, trying to use the native acetabulum rather than a high hip center or pseudo acetabulum, and then be very much prepared to do a subtrochanteric osteotomy as you did. So I think your technique is really, in lockstep with how I would approach this. What's also a little ironic is that where I work, I have access to all the implants, yet I don't see this problem as much. The implant that I've traditionally used for this in my training was the DePuy SROM. It makes preparation and sizing and modularity, dialing inversion, and so forth makes it quite easy. So even though these are hard cases, it makes it easier, I should say. But your approach to this, I think, was great. The fracture distally is certainly unfortunate, but I think you handled it well, and I think it'll heal, and the patient will end up doing just fine.
Yeah, I did one of these a week ago, and I have another one next week. So I think I see a few more. We have a really big catchment area where we're at, and I work at our children's hospital as well. The vascular supply around the acetabulum can be different due to the chronic dislocation. I actually had a vascular injury of abnormal vessel a week ago, so that's been hot on my mind. I think maybe going shorter on your stem would have avoided a fracture, but I also understand that there's limited implants available. I like your technique, how you did that. Even with a small head like that, sometimes I'll use the head as an autograft to help increase coverage. But I think you did a really nice keeping it small and then punching it medial to give yourself coverage. So that looks really nice. I've tried to use SROMs, and occasionally the small spout will even be too small for some of these people with just how small the proximal femur is. And so my go-to stem is a Cohn-Wagner with a DA approach, but I think your technique looks really good. There was a study out of Japan that showed that you can lengthen people up to 5 centimeters, but I totally agree that kind of giving yourself a 4-centimeter cutoff is probably the safest thing to do.
The only thing I'll add to that, I mean, first off, I think that was an amazing job planning this case that you did. That was an incredibly thoughtful approach that you took, which is absolutely the right thing for a case like this. You want to think through the entire case, plan out everything, and have your options available. So that was really good. And the only thing I'll add is, like, if you don't have access to a CT scan, you can get Jude views, which are most often used in the trauma setting, but I find them incredibly helpful in the arthroplasty setting as well. If you've got unusual pelvic anatomy and you don't have access to a CT, they're definitely worth getting.
And then I would always really start off small with your first reamer, like 38, 40. If you can use fluoro, I think Dr. Weaver has an article on that, using fluoro to kind of make sure you're in the right spot, really going slow because it's going to be soft bone, and getting fluoro shots to make sure that you haven't burned bridges. Usually, and I don't just rely on fluoro. I take the reamer in and out, check with my fingers, start to see where you have less or more posterior versus anterior wall, and really be slow on reaming up, and then stopping before you get to a size of cup that you want actually.
Lucas, how comfortable are you with the DA approach in light of the subtrochanteric osteotomy looming? Are you comfortable with still the DA approach in this particular case?
Yeah. So I visited some surgeons out of Bologna, Italy, and we did some cadaver stuff, and they showed me some of their cases, and we did a live surgery there. And you can actually go and split the intermedius. I've also done a subvastus as well. So just DA extensile and go behind the vastus, but it's actually easier just to extend a little bit and then go right kind of lateral third of the intermedius.
Any other comments?
Yeah, so I think it's a very good case that we see on a reasonable number of patients in our setting. And obviously, the first thing to do is try to delay these cases as much as possible. Unless they are painful, affecting their activity, delay the surgery to an extent where they become, affected with their activity of daily living. Don't rush into doing these surgeries. And then, the planning wise, CT, the importance of CT is not to be undermined. So you did a good job in getting the CT. There are a couple of things that I look at the CT. I use the CT to look at. Basically, one thing is to identify, to measure the AP diameter of the acetabulum, and that is, the maximum you can increase cup size, basically. So the AP diameter length, I use it to determine how big of a cup I could use. And obviously, I also look at, the posterior, the wall, the posterior wall, how much of a wall that is available with the CT scan. That also helps. And obviously, getting 3D rendering also helps in, looking at your proximal femur, which could be, deformed, as in the case in this specific patient. So sometimes, it helps to identify which sort of approach might be easier. So CT is a good one to plan all that. And you did a good job in identifying the true acetabulum, the importance of cotyloid fossa, looking at your fat and freeing that fat from the fossa helps in clearly localizing your acetabulum, and also it also helps in you medializing and sizing of your acetabulum. One of the things that you could see in these cases is, impingement post-operatively. So try to leave a sliver of bone anteriorly as much as possible to minimize the risk of post-operative idiopathic impingement. And obviously, try to use the smallest cup that you need to with that. And then as this specification, I don't think there is head left, but if there is hair left, you could consider using a shelf graft to increase the coverage on superior side, definitely. And if you have augment, the same thing, you could use augment as well. And the stem choice for me would be again a short Wagner stem with a varus snake. So and the type of Wagner stem I have has two angle options, 123 and 133, 135 and 123 option. So I use the 123, which helps in the reduction. It will not be as tight, and sometimes it might also help in avoiding even the subtrochosteotomy that might be needed. But whatever is available. And I don't know if you use wiring, and typically, if you do a clean cut osteotomy, you don't need to wire. The Wagner will just fix it, and you don't need wire. And the other thing I think which is important is to identify the tight structures and do appropriate release instead of struggling to reduce these cases. Those will be important, and I would like to hear the faculty opinion. So Lucas, what are your sequence of release in tight when it is tight to do a reduction in these cases?
Yeah, so you can cheat the cup north a little bit if you think you're going to be close on reduction without an osteotomy. And then sometimes I'll ream for a pretty small stem, put a short head. If I have an option for a 32 head, I might put in a 22 trial or a 28 trial head and do a trial reduction. If it falls in without too much of a push, sometimes I'll avoid doing an osteotomy, or I'll let it stretch out for a minute and see what happens. I've used neuromonitoring, but it's really kind of a mixed bag of what kind of information it gives you. And then also I've released the psoas. It's, if the sports guys can release the psoas with their scopes, we can definitely do it in cases like this.
Yes, a subperiosteal release of the psoas can can get you quite some length in that, and maybe even help you avoid an osteotomy. Eric, if I may ask you, have you considered just for completeness lengthening the patient?
Yeah, we considered lengthening the patient, but we actually did all these releases you're talking about, the subperiosteal psoas release, all this. And trust me, after even all these releases we've done, reducing that hip was a problem. We'd initially thought of going for a high hip center, like you've talked about, just to see if we'd be able to reduce it easily. But after almost 30 minutes of just trying to get that hip reduced, we realized there was no way we are getting that hip reduced. So we'd actually released that. We'd even picrusted the the IT band just to get as much soft tissue. We'd done some partial release of the GMAX sling, all that. We'd done all that, and we were actually prepared to lengthen her. And before we went for the surgery, that was a discussion we had with her that you might be potentially long on that side. But the reduction was also a problem. So we had gotten to a place where the soft tissue structures were very tight. So even after doing all the capsular release, all the releases, we still couldn't get that hip back. So part of the subtroch osteotomy, apart from just the nerve, was also the reduction of this hip. At one point, it completely could not reduce.
Thank you. Just as a learning point, could you provide insights on the use of that graft underneath the wire? I mean, what kind of graft did you use?
So that graft was just the bone we got from, you're talking about this graft?
Yeah.
Yeah, so this graft is just the bone that we took from the osteotomy. So we thought, oh, we have the bone, so why throw it? It's still healthy, good bone. Just keep it there as a graft. So we just used the bone that we cut out from the osteotomy. We just put it around there with a sacklage, just as almost a scaffolding graft, but it was just the bone that we had from the osteotomy, yes.
So did you use a circlage prophylactically, or there was a crack? I know you told us distally there was.
So initially, after the osteotomy, so we had done the broaching initially. Then after trying to reduce, this was not going so well. So when we had made the decision to do an osteotomy, we put the wire prophylactically, both on the proximal segment. Let me point this one and this one. They were initially just prophylactic wires, but so the thing that we noticed with this osteotomy, what the osteotomy I think seems to do is it takes away the 3-point fixation almost just from the proximal curve of the femur. So once you straighten that femur a little, the fixation tends to get loose. So we had to rim up to just get a fit, press fit. And we were even happy that we had done those prophylactic wires, because during the rimming just to get a better fit, we noticed a fracture propagating on this distal. That is why we put these 2 wires, though it was still it was a unicortical propagation, but we thought it was even safer to just have those prophylactic wires there.
I saw somebody in progress. Somebody asked about soft tissue releases on the. I just saw on the chat board. I think that I think the GMAX tendon would be my first big release to do, and then anterior capsule, as well as then lastly probably iliopsoas, as Dr. Anderson had mentioned. I sort of have a comment/question in terms of. I like this technique of taking your sort of napkin ring osteotomy and then using it as like a clamshell clamp, if you will, like you did here. But this, I guess, more of a question for Lucas. Like, have you done with your Wagner stem, the splines, and maybe with this, that's probably enough rotational stability, but do you ever consider like a unicortical plate with locking screws as well to augment that fixation?
Yes.
Do you do that routinely?
Yes.
Dr. Luponda, trying to say
Yeah.
something. Go ahead, please.
This patient, there was no way out. It's just to do a total hip replacement. I know there are a lot of technical issues, but also the issue of implants and a lot of intraoperative complications that can occur. So I was wondering whether when because the landmark, anatomical landmark are lost, do you use CT scan sometimes when you start rimming in this case, just to get it right? I mean, Esiyas, sorry, Esiyas.
So we mainly use the SIAM just to get the appropriate tip center, because as you can imagine, on CT it looks good, but trust me, when you get in there, it doesn't look as clear. You have all these soft tissues that have blocked the hip center, so you can't really see. So we used just the SIAM to get the appropriate hip center, that one. For the femur, we did not use it. We did not use an X-ray to do and SIAM to do the rimming for that. Just from looking at, so when we were doing our head cuts, I think, let me show you this. So you can see they still had some part of the head, and actually this had some part of the cartilage. So even just looking at that, you could almost get the native version of it. But since we were posterior, we wanted some bit of antiversion. So we went with a little antiversion just to get us a good stability of this hip. So no, we did not use it for the stem, but we used it to get the hip center for the acetabulum.
Yeah, I think that is important because because of severe dysplasia, everything, all anatomical landmarks are lost. And for the cup, I think it's very important to make use of a SIAM so that you can at least get the right center of rotation of the hip. And of course, the soft tissue release is quite as important as I've just alluded out.
Perfect, thank you. Any more comments, or if there's anything else to say, we can go on. Otherwise, we can go with Dr. Esiyas and his presentation.
Yeah, I think that would be great, Mohammed, just for the purposes of time.
Okay. If you could you please stop sharing your slides so Dr. Esiyas can share the slides? Thank you. Dr. Esiyas will
Yes.
present a transverse acetabulum fracture, which was managed with total hip arthroplasty. Go ahead, Dr. Esiyas.
So can you see my slides?
Yes, thank you.
So greeting to everybody here. So I will present the case of chronic transverse acetabular fracture with posterior wall fracture treated with total hip replacement. I am Dr. Tadesse Esiyas from Sodo Christian Hospital. Before just diving into the case, I want to say a few points about Sodo Christian Hospital. It is in the southern direction from capital Addis Ababa. And if you take public transport, it will take you like 7 hours. And the Sodo Christian Hospital is a general missionary hospital. It got different departments and orthopedic departments, one among it. So yearly we see around 8,000 patients in our outpatient department, and we do about 2,000, including both major and minor cases per year. And most of our cases are trauma, and the chronic case and the complicated case from the other centers. nowadays we start to do joint replacement surgery on a regular basis in some sport case. So coming to the case, I had 20 years old male patient. He presented to our hospital after a road traffic accident, and he came to our hospital after 5 months with complaint of hip pain, and he had severe pain and just after trauma and the swelling around the groin area, and he went to bone setter and got massage. He has no other traumas. He has no history of smoking, and he's a breadwinner for his family. On physical examination, he came to us by wheelchair. He has shortened and internal rotated and adducted left lower limb. Neurovascular structures are intact, and he has significantly limited hip range of motion, and he has flexion contracture of hip about 40 to 45 degrees. On investigation, blood workups are normal, and his serologic status is negative. So on imaging at that time, our X-ray machine was not working, and we sent him to outside, and we only got AP view. And on this X-ray, you see significantly medialized medial wall and proximally migrated head with dense bone around the false acetabulum superiorly. And you can appreciate how much it is medialized and moved proximally. So on the axial CT scan, you see irregular head. You see irregular head which is eroded, and the malunited medial wall. And there is on this view on the second axial cut, you see how much it is widened and how much it is malunited. On the coronal views, you see it's how much malunited and the healing in malunited position in a significantly medialized position. This part of acetabulum is the normal remaining one. This one is significantly medially shifted. And on this cut, you see the flake of bone, which is part of posterior wall, just covering the femoral head in the false acetabulum. So on the sagittal view, you see the flake of bone that I'm talking in the previous slide, which is uniting and it's just hanging over the head. On the 3D image, you see how much it is medialized, and on this view, you see this part of acetabulum, which is the normal one, and posteriorly there is a normal wall which is displaced and engulfed by the newly forming bone, which is covering the head of femur in the forming false acetabulum. And on this view, you see how much it is deficient. The head, the part of acetabulum which is displaced proximally, and there is a remaining part on the inferior part being attached to the ischial tuberosity. And you can really appreciate here how much it is close to the sciatic nerve, and then the defect, the acetabular defect on this. So after taking out the head out from the acetabulum, you can really appreciate the defect and how much it is significantly medialized, and the remaining part, the true acetabulum, remaining part of true acetabulum and the false acetabulum, which is displaced and having significant defect at the center. So we, after investigation and imaging, we try to list his problems. One of the problems are the dislocation he has. He has significantly proximally migrated head with medialization, and he has a acetabular fracture which is malunited, and the medial wall is significantly medialized. And he got a acetabular defect, and of course the soft tissue component, he had adduction and the flexion contracted. So we promoted these problems, and then we came up with plan, because we were working in a resource limited setting. So our plan mainly focused on two things: soft tissue related things and the components we had in our setup. So regarding soft tissue, he obviously, as I have mentioned, he has adduction contracture, and he has flexion contracture. So my plan was just to do percutaneous adductor tenotomy just preoperatively, because I thought that will make it easy during intraop, because obviously we'll go through posterior approach and then we put patient in lateral position. It might not be as easy to do the tenotomy percutaneously. And then to do anterior part of release just after putting the components. So regarding the bony things, the way I planned is just to osteotomize those hanging both fragments proximal and distally attached to the ischial tuberosity, just osteotomize it incompletely and just close it to have something which look like a stabulum, just as someone is closing the door, and then fix it, and then reconstruct the medial defect using head as impaction graft, and to use a high offset stem just to medial lateralize the center of hip and to restore the femoral offset. So we did it with spinal anesthesia, and then we put him on lateral position. We prepped the drip, and then clindamycin was given and made prayer. And through the posterior approach, we made about 15 centimeter skin, wide incision, in line with the femur, and we curved it toward posterior spherical spine proximally with split G marks and the tensor. In line of skin incision. Sorry for the disturbance. Exfold. The first thing I did was to do release of gluteal sling during the approach, and then we found sciatic nerve, because the fragment, as I have told you, is very close, and the head is very close to the sciatic nerve, and I expected all scar around. So my plan was to just dissect out sciatic nerve, finding it just behind the quadratus femoris, all the way to the sciatic foramen. And then we divided short external rotators with quadratus femoris and with capsule as a unit, and then we put a stay stitch there. And the head was in the false acetabular. We made a neck cut, took out the head with corpuscle and preserved it for graft. And we cleared out scar tissue around the false acetabulum and the remaining part of that true acetabulum. It took us a long time to clear out all those scars, because that helped us to clearly study the fragments, because he came up after like 5 months, because the fragments are embedded in the callus. So we just cleared out all the scar and then stated the fragment where to put our osteotomy and make osteotomy cut. Then we osteotomized the wall right here after clearly staining from inside, and here partially without making it complete, and then we just hinged it to bring it together, and then we plated it with the reconstruction plate, and then we augmented that with screws. And then we removed that stabulum carefully, because the fixation is not that much and the fragments are very small. So we started with 42 and then to 47 gently, and then
I think he broke up.
Do we lose Tadesse?
Yeah.
I think this is a really nice case with a number of different techniques that are key. I think it's nice how we use the head graft to in the absence of augments and revision implants. I think that's a really nice technique.
I agree. You know, we do a fair number of total hips for acute acetabular fractures, and particularly in the elderly, the posterior wall can be pretty deficient. And one other, it sounds like they were able to use the remaining posterior wall to reconstruct something to ream against, which I think is a brilliant idea. Yeah. If that hadn't worked, then I have hemisected the femoral head before and plated that to the posterior column and ream into that, which gives you something to get a press fit against if you have a large segmental defect at the back of the cup. But this is a great case, and they talked through it very nicely.
Yeah, I think that this is amazing. I think that I've seen the end of the presentation already. I think he did a great job. It looks awesome. This is like true artwork. I think there's no playbook for this. I think that there are probably several ways to get a good product out of this, which is sort of evidence of how challenging it probably was. But yeah, I think using the femoral head as either a structural graft or morselized cancellous are both good options, and the plate, plus or minus. I wondered even if you could have just bolted the head where it was, and used that as like a buttress and then reamed into that as a graft. But I mean, this is a really great job. It looks wonderful.
Yeah. I've seen Tadesse's work over the years, and he always has questions and sends out emails to a group of surgeons, asks for advice, and then he usually does something of his own that incorporates a number of our opinions and is usually just a really beautiful combination of techniques and advice. So really talented surgeon.
What does the faculty make of the I've seen this when we do acetabular, or if sometimes the ischial bone buttress rotating internally, like in this case, and sort of leaving bare the posterior coverage of the acetabulum. And at what stage would you give up on bringing it back out, externally rotating it so that it can come back to where it's supposed to be? At what stage would you give up and just say, okay, I'll fix the hip where it's supposed, where as is?
Well, I think here, there was no unrotating the posterior column. I think the one saving grace of this case is there was no discontinuity. And so, there was no need to derotate it. For an acute fracture, I try really hard to restore the normal anatomy, at least pretty close before preparing the acetabulum, because you want to try to restore the position of the ischium. But in this case, I think it is what it is, and he did a nice job of placing his cup despite that problem.
Victor, did you have a comment you wanted to make?
Oh, yes. Sorry, guys, I'm joining late. I was just grabbing out of a case here. Now, I admire the technique that he used to eliminate the femur in order to analyze what is left of the acetabulum there and the defect that you're faced with. I think that really prepared you well enough, and it's a technique maybe we should adopt, especially dealing with these delayed acetabular defects that present to us, especially on this side of the world. Overall, I think this is an excellent case. The team really did a good job in dealing with it and addressing the defect and using the bone graft. The role also of the cuts, the CT scan cuts, the way they did the transverse cuts gave you a better picture of what was left of the floor. So yeah, I think those are my comments, but excellent case, guys.
Sammy, any comments from you from the Ethiopian side?
Yeah, so it's a very nice case. Well done, Tadde. It's a good technique, how he tried to lateralize the cup with morselized bone grafts as much as he could. I didn't get his technique. I didn't hear it, but I guess, as most of you, can you go back to the morselized bone graft that he used?
This one?
Yeah, so I guess he tried to Ronger It's usually I think he used a nebular or ronger to collect this bone graft. It seems like, but I think that one of the ways to get a good bone is from the head. I typically use 2 towel clips on. Two towel clips, to stabilize the head like this, and then I use start from the smaller reamer from the neck side, and keep this, increasing the size of the reamer to get as much bone graft as much as possible to keep the cap as lateral as it could be, and use 1 or 2 small reamers minus with reverse rim to impact the mortualized graft onto the acetabulum. That's one thing he could do instead of trying to use a ronger. It will take time, and of course he can get even more bone graft from rimming the head with this. And the other thing I might add to this is the cap could be bigger. If you see on the post-op X-ray, if you go to the post-op X-ray, he did a couple of things to. It's good that he identified the native acetabulum and brought the cap to the native acetabulum. And the other thing is he used lateralized stem to keep it out of impingement as much as possible to increase the horizontal offset. But still, you see the trochanter is impinging onto the acetabulum, that area. So one of the things that could help him is use more bone graft, as we discussed earlier, and the other thing is increase the cap size. So when he increased the cap size, he could also minimize the impingement that he is facing here. And the other thing is obviously this is Zimmer cap. But I don't think they have a lateralized liner, but the lateralized liner also could help in keeping the patient out of impingement, basically. Otherwise, he did a good job, and it's a well done, executed case. Thank you.
Do you like to perform the soft tissue release and then to recreate an acetabulum here? Do you worry about dislocation? How are you trying to prevent that?
Yeah, definitely. Dislocation is, one of the things that you should be worried. But to the most part, this is a very tight case. It will be tight around it, and the chance of dislocation is probably less than. It will actually be more difficult to reduce the SIP instead of worrying about dislocation. But trying to increase the version and maybe using a lipped liner when you don't have other options. And if you have dual mobility, maybe dual mobility could be another option. But I don't think dislocation is a worry here, unless there is impingement or things like that. You could obviously osteotomize the impingement on the acetabular side. You could also osteotomize and try to minimize the impingement as much as possible, because one of the risks could be impingement on different range of motions.
So like osteotomizing this piece of bone away to avoid the greater. I think.
Yeah.
Yeah, again, as a training point, something that is interesting for me is the approach. So when the hip is dislocated, you lose the reliable landmarks to put your cuts, to do your approach, place your retractions. Does any of the faculties have any comment on this part?
Sorry, can you repeat the question? I'm sorry.
I mean, when the hip is dislocated for like 6 months, it's a little bit difficult to find the right approach. He did the posterior approach, but the landmarks are completely vague in that case. I mean, is there any trick you would, recommend for younger generation of surgeons to find the appropriate approach?
So personally, I do a lot of my primary hips through a direct anterior approach, but the majority of my complex cases I do through a posterior approach. And I think with the displacement of this fragment and the remodeling all being posterior, I would do a posterior approach on this. My expectation would be that, you know, doing this through an anterior approach would have its challenges. I think Dr. Anderson probably would consider doing this through an anterior approach, but I would let him answer that. I just think that we actually trained in the same place, but the anterior approach has become more and more, you know, people doing more complex cases through that. But I would do a posterior approach on this page.
Yeah, I would do anterior in almost everybody. I find it actually in some of these cases easier because you're looking right at the anterior head or anterior neck, and can do kind of plan your osteotomy with fluoro. When these cases are really in the pelvis, it's sometimes if you have a cup in the pelvis, you can actually go on the inside of the pelvis through more of a ilioinguinal approach. Some of these, if you go through posterior, the sciatic nerve is tucked up right against the ischium. Your troch is against the iliac wing. It's really difficult to do a neck cut and see the neck. And so you're kind of flying blind a little bit. And so sometimes anterior approach is actually easier just with the position of the hip and the available anatomy. And I probably wouldn't have done a posterior osteotomy in this case and just would have packed bone graft into that area. I probably wouldn't have, in that case, probably would not have morselized it. I would have used it more as a bulk and pinned it and screwed it into place and then reamed into that to fill the gap in the posterior segment there. So just subtleties. And then I would have taken advantage of ability to use fluoro easily with the supine approach, although others can use it in posterior as well.
Lucas, you're saying that would you have like screwed in that femoral head and then reamed into it without trying to reduce the acetabulum? Is that what you mean?
Yeah, correct.
Okay.
So, Lucas, how would you have access to the posterior aspect, though? I get like the fact that you could use head, as a shelf graft, especially when you are, dealing with a posterior superior defect or something like that. But this is a pure posterior defect where I think you need a buttressing plate like what he did instead of a screw, which would definitely, compromise the stability of your cap. And because the wall is there, for me it's a posterior approach case. I think I don't know your thought process. If you could elaborate on that, you would use the plate. That's what you said.
I would typically not plate. I would do bulk allograft, head, or one off the shelf, and then I would reinforce it with like a cup cage. I have a PowerPoint at the end I can show where you can use just even a recon plate over the top of a cup, rather than if you don't have access to a cage. So that's the technique I would use.
Yeah, I think that if you use a cup, if you use a cup cage, definitely, you are basically treating it a little bit differently. But if you want to use a primary cup like this one, I think we need to use a plate to buttress. It is actually, structural graft, and it has to be buttressed so the cup is stable enough. It will, without a cup cage, with a primary cup, I think we need a strong, robust fixation from the posterior side.
I agree. I think if you don't have the options of being able to drill holes and put screws everywhere, essentially what I'm using with a TM cup or revision cup is I'm using that as my posterior plate. I'm getting inferior fixation, pubis fixation, dome fixation, and then I'm packing bone in the back to get long-lasting fixation in the end, but I'm not relying on posterior plate or buttress.
We have numbers of pelvic acetabular injuries in our institute. Almost every day we have 3 or 4 cases, and we are fortunate enough to have 4 acetabular surgeons who actually take care of these acute cases, and therefore we have very few neglected cases for pelvic and acetabular. And I will agree with the previous speaker that in that scenario, we normally tend to put a bone graft at the defect and don't bother much to reduce the fracture, and probably use a little bit bigger cup and do some screw fixation on the cup, and that work very well. But in a time that we think we need some reduction, we'll probably involve our team, and they'll do a posterior approach. And at times we get a lot of difficulty in reducing those fragments. And end of the day, we might end up having a bone graft impacted and a cementless cap with a screw, and that's worked well.
There was one comment in the chat by Dr. Milkias, who has been one of our faculty member and presented a fantastic case of acetabular fracture in one of our previous conferences. Milkias, did you want to make a point about that, about medialization?
Thank you, Dr. Agrawal. It's quite interesting case, and I was wondering, I just raised the point, it looks like a bit medialized, and probably it's just answered by kind of using a bigger cap, or rather approaching it posteriorly for a better reduction. And I know it's not going to be easy after 6 months reducing such a malunited acetabulum, but I was worried about the impingement, and you have already mentioned about taking some part of the hanging bone over there. So I just raised the point probably on the beginning part of the discussion, and it's more or less answered. Thank you.
Thank you, Dr. Milkias.
Yeah.
Okay, one last question I have. Dr. Esiyas, in his post-op, mentions that he did some heterotopic ossification prophylaxis. I mean, if you go to post-op, yes. Yeah, okay. So I would like to know if what's the current practice for heterotopic prophylaxis here in the United States? Do you consider something like that?
Mike, do you guys have any prophylaxis for heterotopic ossification?
The only time we do heterotopic bone prophylaxis for acute fractures now is for dual approaches. So for a Coker in an acute fracture, we would not do heterotopic bone prophylaxis. We also use it if we're taking out heterotopic bone. So I'll use the only time I use radiation actually is in someone that I'm removing bone, and then if someone does have a history of HO on the other side or something like that, I might consider it. Or I don't know that it does a lot, but sometimes I'll use Indocin, although the data on that is a little bit weak.
I looked it up.
I probably would not think to use it here.
I looked up the literature a couple years ago, and indomethacin was almost as good as radiation. And with wound concerns and infection concerns, I'll lean more towards the anti-inflammatories. Then there was another study that showed Celebrex was equivalent to indomethacin with less GI upset and better compliance taking it. So I've mostly just used Celebrex or equivalents.
I also do Celebrex for these patients. I don't I do most of these at a community hospital that does not have radiation oncology service. So I'll do Celebrex for these patients. If I anticipate that I really think they're at high risk for post-op HO, I will do them at our medical center where we do have external beam radiation, and I'll consider that as well.
We do give indomethacin, especially for the patient who are at a higher risk, because our radiation center is far away from our hospital. So it's easy for them. The compliance is very poor. So I think oral indomethacin works better with them.
I think these delayed cases in our settings, it's sort of self-declares whether this is a HO former or not. So by the time you get to this patient, 6 months down the line, if you see HO around, and that's the case, that will most likely grow HO. So in those cases, I would use prophylaxis. Otherwise, in this case, I didn't see any form of HO for being formed in the pre-op CT scan. And if I don't see that, I don't bother that much. And if the obviously, the abductor, if the minimus is, damaged or doesn't look good, or if it is confused much during the surgery, I would debride that as well. But if I use anything, I would use indomethacin. Radiation is not something that we have it easily available, but I would consider radiation in cases of ankylosing spondylitis or high-risk patients who have had extensive HO preoperatively, things like that. For the written ones, I don't use any prophylaxis.
Great final discussion points, everybody. Thank you all. Go ahead, Mohammed. I think given the interest of time, Lucas, I'm sorry that we can't get to your case, but I hope you agree that the conversation we've had from these three was really stimulating.
Absolutely. Great. Thanks for including me.
Go ahead, Mohammed.
Okay, thank you all faculties and presenters. Is there anything else anybody wants to add?
Any final thoughts from any of the faculty?
I'd just say thank you very much for sharing some really interesting cases. I've certainly learned a lot seeing them. So thank you for sharing it and spending your time with us.
Yeah, likewise. And also I would say it's incredible, what you guys on those cases, what you're able to do with, some limited access to some resources that we take for granted in a city like Boston, Massachusetts. So great job with, with those cases and with the tools that you have.
Yeah, thank you. I've had a very good opportunity to learn from others. Yeah, we are, of course, less privileged with the type of implant that you are much more privileged. But I think we have seen cases that have been done with our colleague, and they are reasonably good cases despite the difficulties that they have. But what I should say, the pathology of the hip are diverse in nature, and therefore they're very difficult to manage. Despite the fact that the demand have increased. Of course, the demand of total has increased because of the improving on the surgical technique, but also the biomaterial for the implant that we use. But for any competent surgeon with all the fancy implant that you have, we should be prepared for the revision of this young patient. So I think we have to have to be very clear on the absolute indication of this patient for total hip replacement, because the revision rate is high and it doubles with every revisions. The complication doubles with every revision. So thank you very much.
Thank you, Violet. Great point, and also a call for increased availability of these, not only the surgical techniques, but the surgical implants in limited resource settings around the world. I think these cases demonstrate how essential those are.
Yes, Victor here, Kieran. Yeah, I think just my final thoughts are we need to really document and talk about these cases, especially from a part of the world where we are faced with such delayed cases. I think documentation will help us get better guidelines, which we can use in tackling these kind of cases in the future. So that's of course calls for collaboration and visiting and all that. So keep it up, and I think it's a very good initiative you're doing.
Absolutely. I think documenting them through research, even just simple retrospective case series, would be very, very helpful for us to really put on the global platform the kind of complex cases that are being tackled by you guys who are working even with limited resources. It's really commendable and amazing work you guys are doing. So thank you for all the case presenters for sharing today. And I think with that, we'll wrap up. So Mohammed, go ahead, take us to the end.
Thank you. So for those participants who do the pre-survey and post-conference surveys, we will provide the certificate of participation. This is our WhatsApp channels. You can participate if you scan these QR codes. We are planning for another meeting on September, October on pediatric orthopedics, but stay tuned for our August 3rd second meeting for this total hip arthroplasty in young patients conference. Thank you for joining us today.
Thank you, everybody. If these conferences are interesting and you enjoy them, please give us feedback so that we can keep making them better and keep continuing them. Thank you all so much for participating.